It is February 22nd, 2024. I'm Dr. Deuk, the CEO and founder of Deuk Spine Institute. We're here with a patient who just underwent a Deuk plasma rhizotomy for facet joint pain in the back of her neck. And now we're going to fix two discs, C5-C7. She has herniations, annular tear with irritation of the nerve roots. So she has symptomatic disc disease. The first step for the Deuk laser disc repair, which is a full endoscopic transdiscal surgery, it's been peer-reviewed and published, is to gain access to the disc through the front. Shot. And we're going to pick one disc. 2, 3, 4, 5, 6, 7. 5, 6, 6, 7. Everyone agrees? So we're going to start with 6, 7. Shot. I'm literally touching her spine. Shot. And let's get an AP view. I want to check the lateral view to make sure I'm at the right disc, and I'm over the disc, and I want to check the AP view to make sure I'm in the middle, which I am. So at this point, we're going to enter the skin with the needle, and we're going to go straight down to the disc. Now, I always go to the opposite, I start at the opposite side of the worst arm. So if it's her left arm that's bothering her, I'll start on the right side. If it's her right arm bothering her, I'll start on the left side. Shot. All right. So let's get a Coker AP. And shot. Perfect. Lateral. So we're in the middle. And if you're doing this type of surgery, you want to be sure to, use your lateral and AP view x-rays to navigate to the disc where you're going to do a discogram. And then once you've done the discogram, you can see the tear in the back of the disc. Shot. Sometimes you can even see the herniation. Shot. All right, there it is. Shot. All right, perfect. So let's show the audience on the x-ray, Jordan. Where is the annular tear? Right there. You guys see the black line? That is the tear in the wall of the disc. That's where all the neck pain comes from. And then the herniation squeezes out through that tear. So I'm going to numb up her skin with some Novocaine so we can make a cut. Now she's asleep. She's completely out. She's under general anesthesia. And she's snoozing comfortably. This is relatively bloodless surgery. We're not going to lose any blood. It's very safe as long as you know what you're doing. I've been doing it now for 17 years. This is the one drop of blood we're going to lose. Okay? Shot. Now, I need to make sure that our equipment gets to the right spot. Shot. Now, you could show the tip of the guide wire there. Show the tip of the guide wire there. Can you see the arrow, Henry?
Yes, we can.
All right, come down a little bit, Jordan, because they can't see it. See the black line? That's the tip of the guide wire. We're going to use this guide wire to introduce what's called a dilator. Shot. A dilator is this right here. Can you guys see it, Henry, on the camera?
Yes, we can.
It's basically a surgical pencil that has a hollow tip, and it's going to slide down the guide wire, and while it does that, it will spread the tissues apart. It doesn't cut anything. It's not a cutting surface. It's a spreading. And shot. You want to spread tissues so that you don't damage them. That's the beauty of this surgery. If you're small enough instruments and they're shaped properly, you can actually not damage anything as you pass through the body. We call it spreading, okay? And there's another name, blunt dissection. But basically, we're not damaging anything between the skin and the spine because we're spreading the tissues apart. Shot. And let's get an AP view. Now we're going to pass through the front of the disc with this dilator. Once again, spreading the fibers apart, not cutting or damaging anything. That's why this surgery is so minimally invasive. It's because we're not cutting or damaging anything except for the skin. And the skin cut is 4 millimeters, just 4 millimeters. Shot? All right, so we're entering the disc at this point, and I'm going to go all the way to the back of the disc where the herniation is. More importantly, I'm going to go to the back of the disc where the tear is. It's actually the tear in the back of the disc that's causing her symptoms. It's quite interesting. You can see that she has a rotation of the spine right here. If you look at the back of the vertebral body, you could see a double shadow at C7, meaning that it's offset. Yeah, right. No, go to the right. Right. Stop. There. See the little line going down to the left? There's one on the right, there's one on the left. That's the back of the vertebral body, and it means that it's rotated compared to the one above. AKA she has scoliosis in her spine. Now, we don't need to fix the scoliosis. It's not causing any problems for her. But we do need to fix the tear. As we're doing this, introducing a tube, I want to be very careful. I want to watch my x-ray. Now, Jordan, show us the tube that's going down her trachea for breathing. So one in the front, it's called an endotracheal tube. Show us the tube that's inside her esophagus. There it is, braided. All right, here we go. We're going to advance the tube. Now, Henry, while we're doing this, can you show, come on, Jordan. Can you show our audience, that's it?
Yes, sir.
Can you show our audience a video explaining how a disc can cause so much pain? Yeah, inline traction. 2, 3, 4, 5, 6, 7. Welcome back. Our patient, we've placed the tube, and you can see right down the tube. At the bottom is the first pieces of herniation and our laser. Now, what I'm seeing here is that these pieces of herniation are actually not soft, they're hard. And that means that this herniation has been here for a while. I'm going to reset the camera. All right, that's good. I think our exposure is too high. Let's turn it down one notch. One more. Perfect. All right, so these are our first pieces of herniation. They are at the bottom of the tube. If you look at the x-ray picture, you'll see the tube, the very tip of the tube is at the back of the disc where the annular tear is and where the herniation is, and that's what we're seeing. We're just going to use our laser. Now, to give you an idea of how precise the laser is, it's the most precise tool a neurosurgeon can use. There's nothing more precise. Not even radiosurgery is more precise. The precision of most surgical instruments is perhaps 1 millimeter. This laser is precise to literally 20 times more precise than 1 millimeter. So 0.05 millimeters. To give you an idea, see that tip of see the glass down there, the glass fiber that the laser energy is coming out of? That's called the laser fiber. That is half of a millimeter wide, 0.5 millimeters. So our view here is quite zoomed in. Oh, Henry, by the way.
Yes.
Jeff from San Diego, who's producing our movie,
Yep.
wants some endoscopic footage, lumbar, high quality. He was asking if we have any 4K footage.
4K, that's a good question. I know the
I
quality.
think these lumbar endoscopic, I think these cameras are 4K, aren't they, or are they not? Maybe they're just high def.
I think they're high definition. They're definitely
Yeah.
1080p, but to 4K, that's a very good question. I'm not sure.
Yeah, well, why don't you pull a couple of the lumbar endoscopic views, surgeries, where they show the tear, the annular tear and the laser cleaning it?
Of course.
And he wants to incorporate them in the movie.
Not a problem.
So if you can pull like 2 of them that are high quality, good visibility, good lighting, you know, well balanced.
Yeah.
And do you have Jeff's email?
I do not know.
All right, remind me to email you his contact, okay?
Copy that. Not a problem.
You can work directly with him and his team.
Yes,
But
sir.
they're going to start shooting the movie in June.
Beautiful. Not
Yeah.
a problem. I'm here.
All right, let's show the audience how this surgery actually works. All right, welcome back. You can see from our video how the laser surgery we do, the Deuk laser disc repair, how it actually can be used to repair the tear in the back of the disc using a laser to clean the tear out so that it will heal. Your body cannot heal a tear in the disc when there's herniation stuck in it. And everybody with a herniated disc or bulging disc, ruptured disc, protruding disc, extruded disc, slip disc, all those disc injuries all have one thing in common, 2 things in common. They have an annular tear and they have a herniation of the nuclear material out the tear. And that's what we're fixing. Okay, we're cleaning that up so that the patient will heal their disc naturally and you don't need a fusion. So every doctor that does fusion or artificial disc, they would love to be able to do this surgery instead. They just don't know how to do it. And the truth is that they get paid a lot more money doing fusions than this type of surgery. They get paid a lot more money, but that's not good for patients. Patients should get the best surgery for the patient. And that's what we provide at Deuk Spine. Unlike other doctors that just recommend fusions and artificial discs, we can do fusions, we can do artificial discs, we can do endoscopic laser surgery. We do it all. And the surgery that we recommend the most is this surgery because this is the best for the patient. Fusion is really almost never the best for the patient. Now that said, we do have a fusion coming up, hopefully next week, but we may not, we may have to postpone it. The patient is having a lumbar fusion because she's already had the artificial disc and it's popping out. and nobody wants to help her. So she's come into Duke Spine to get it fused. So we're doing a fusion on a patient who has an artificial disc in their back where the disc is popping out. And it's a really dangerous situation for her. And that's what I warn everybody about. These artificial discs pop out. They don't believe me. Well, you're going to find out next week, hopefully. And on top of all that, our patient has issues with coagulation. So hematological issues. So not only did they screw up her spine by putting an artificial disc, but that disc is popping out and creating complications like blood clots. So I wonder if the blood clots that she's getting, the pulmonary embolisms and the DVTs, are related to the disc pushing on her inferior vena cava. We were supposed to get imaging done to look at that. So let's make sure, Henry, will you grab whoever her rep is, talk to Sam, and make sure that I see that study. I need to see it today.
Copy that. No problem.
Okay. So, folks, I keep telling you all, warning you about surgeons that are putting artificial discs and cages. This is this dangerous surgery for you. Don't get it done. It's totally unnecessary, the fusions and artificial discs. This surgery right here is the safest surgery available. We've never had a complication from Deuk laser disc repair in the neck. But there are lots of complications with fusions. Not at Deuk Spine, but with other doctors. All right, any questions?
Yes, we have a question from Simo134.
Hi, Simo134, welcome.
They ask, hi, Dr. Deuk, with a central disc bulge pinching the cord, will you need to take out some of the thickened ligament as well, or only just the herniated disc and scar tissue?
Yeah, Simo, great question. Just the herniated disc. The ligament is not the problem, okay? And just the herniated disc is all you need treated. As a matter of fact, right here in the center, right here is where your herniated disc would be. Very easy to get to with this procedure. I don't need to take the ligament out. Now, if there's ligament here that's pinching your nerve or spinal cord, then I would remove it as well. If it's in the back of your spine, you don't need to take it out. So I have to see your MRI to verify that, but I never have to take the ligament out. Typically, we just go in the front and do what you're seeing right now. There are even bone spurs here, right there, that I've cleaned out. You guys see that?
Yes, we do.
Yeah. But everything's going well. She's stable. She's completely asleep for the surgery. She's comfortable. By the way, this patient has already had the Deuk laser disc repair lumbar and the Deuk plasma rhizotomy and the piriformis release. She had it done 2 days ago. So she is here to get her neck, her thoracic, and her lumbar fixed. So we did her thoracic DPR for facet pain. We did the lumbar DPR for facet pain. We did her DLDR at the L45, and we did a piriformis release. No, sorry, an SI joint. And she has zero pain in her back right now. She's so happy. And now she's here for her neck. So she's a patient who we've already treated in the past, and she's back for a different body part, her neck. I think she's going to be really happy with the results. I've got about 2 minutes on this disc left. I don't see any more herniation. There may be another piece or two that I haven't, hasn't visualized it, but so far, really good. By the way, for those of you who pay attention to these surgeries a lot, the anatomy, what you're seeing here is that crack that I'm working in is the back of the disc. That's where the tear is and the herniation. This right here is the herniation that I'm using the laser to peel away. And I'm removing 0.05 millimeter at a time. 0.05. This is the most precise tool in all of medicine, the laser. It is the safest and most precise tool, but you have to have it done right, and Deuk Spine does it right, okay? We do it right. I don't trust other people to do it right, and you shouldn't either, until they have a proven record where they're showing you all their surgeries online for you to watch, so you can make sure they do it right. This is it. This is the last of the herniation right here. You guys see the laser just zapping it all away. It's beautiful. All right, I'm going to flip, and we're just about done. Another 30 seconds, and then we're going to go to the next disc. Okay, let me just check this foramen. It's looking good. I don't see any more herniation. The end plate is there. That's number 6, and then number 7. The herniations are all gone. So we're done here. And we're going to go on to the next disc.
Go on, please. Thank you.
Now, the first doctors to do anterior cervical transdiscal endoscopic surgery were the South Koreans. And they were the ones who trained me on the endoscopic. Okay? But they only do endoscopic. They don't do laser. And their technique is not as good. I had to modify their technique and make it better, because they had some faults, some problems with their technique. They had a few patients who were paralyzed and a lot of nerve damage, and I improved on their technique and made it better. And we call it the Deuk laser disc repair, because we're doing something they don't do. We're actually debriding or cleaning the tear. No other doctor does that. I figured it out that that was the problem that other doctors weren't doing, which is why their results were not good. And once I started doing the annular debridement, well, lo and behold, people's neck pain went away, their back pain went away if it's in their back. And the reason is we're getting rid of the source of inflammation and pain. And we figured that out here at Deuk Spine Institute, Arias Deuk-Machen and myself, and we published it many, many years ago. 12 years ago now. So that's already been published. All right, let's see here. It looks perfect. Let's go north a smidgen so we can see C2. There it is. So 2, count for us. 2, 3, 4, 5, 6, 7. We're going to move up to number 5, 6 next. I've taken the tube out. Shot. You guys see the tube is now gone, right?
Yes, we
Tube
do.
is out. And I'm going to move the dilator. Shot. We're going to go up 1 disc. Okay. So here we go. Everybody ready? Head neutral. And coming out of the disc, we're out. And now I'm going to move along the spine. I need an AP. I want to make sure that I'm staying in the middle. We call this the Deuk Spine Slide. We're the ones who invented it. We're the first to do it in the world. And what we're doing is I'm sliding along the ALL. Yeah, lateral. I'm sliding along the anterior longitudinal ligament between the 2 longest coli muscles. And I'm sliding up to the next disc. We're almost there. There's a little bump. We're there. Let's make sure we're in the middle. So you have to use biplanar fluoroscopy to verify your position. All right, we're way off to the side. See, that's why you have to do that. That's perfect. We're right in the middle. Let's go back to a lateral view. Anytime I move the dilator on the spine, I always verify position. All right, so I'm a little north of where I want to be. That's right there. Everybody ready? I just moved. I'm going to check my AP view one more time to make sure I'm in the middle. You don't want to enter the disc to the side. You want to enter in the middle. All right, a little bit to the left. Stay there. I'm going to move a little bit to the right. And I can feel that, and I moved about 3 millimeters to the right. Perfect. Lateral. Now I got to go back and check the lateral again and make sure I'm in the middle. Shot. All right, it looks good. I may want to move just slightly north. Shot. Shot. That's probably as good as I'm going to get. Shot. All right, I'm anchoring. Let's go back to an AP just to verify. And if you do this kind of surgery, you got to go back and forth, AP, lateral views. That's perfect. We're right in the center. So I'm going to go ahead and enter the disc at this point. Shot. Uh-huh. Yep. Now, we're in the middle. And let's pipe clean. We're going to get the schmutz out of the dilator. And then I'm going to do a quick discogram. Come on, Jordan. Shot. All right. Shot. 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 All right, perfect. Got the schmutz out. Now we're going to do our discogram to see the tear, hopefully. Shot. And there it is. Show us the tear. That's the tear. All right, so definitely an annular tear. Now I'm going to advance the dilator into the tear because that's where we're going to go clean out the tear. And every time I tap with the hammer, I'm feeling exactly how much this dilator is moving, how much the tube is moving. You have to have a really good sense on your hands to be a neurosurgeon. And I know some neurosurgeons who are not so good with their hand sense. I won't mention any names, but you're going to want to stay away from those people. I remember one time I was working with another neurosurgeon doing an aneurysm, a brain aneurysm clipping, and I exposed the aneurysm just perfectly. It's called the exposure. The hardest part of an aneurysm, in my opinion, is the exposure. Some people think it's the clipping. Of course, the choice of the clip is important too, but the exposure went perfect and the aneurysm was ready to be clipped. And then the surgeon came in with his shaky hands, the senior surgeon, my boss at the time, and poked the aneurysm and popped it. And I mean, incredible. The whole field just filled with blood. I never seen it bleed so fast. But that's what aneurysms are. They're arterial bleeding structures. And, you know, I won't say anything more, but the patient did not do well. And it's really upsetting because I feel like I could have clipped that aneurysm easily, but my senior surgeon wanted to do it, and his shaking hands popped the aneurysm. Yeah, there's a lot of problems with healthcare. A lot of problems. And by the way, he's an aneurysm surgeon. I wonder how many more fuck-ups he's had and people he's killed. Huh? No, that was in residency. But I don't want to say who he was, so. Yeah, good guy, nice guy, but I'm sure he gets a lot of patients because he has a great personality. But I would be very careful. Okay, who's next on the question list?
This next question comes from Big John on YouTube.
Big John, never heard of this guy. Hi, Big John, welcome. I need the pedal here, please.
They asked, hi, Dr. Deuk, would you be able to give a percentage between the cervical spine patients who have basically pain/tingling as their main issues compared to the patients who just have radiculopathy and arm weakness?
Sure. Yeah, if I had to guess, I would say um, probably 97% of patients with symptomatic disc herniations in their neck have neck pain and arm symptoms. Maybe 3 to 5% have just arm symptoms, and probably there are 10% that have just neck pain. Maybe 20% 15% with just neck pain. So you don't have to have neck pain and arm symptoms. You can have just arm symptoms. You can have just neck pain. As a matter of fact, you can have just myelopathy, which is compression of your spinal cord, which causes balance difficulty, coordination difficulty, things like that. So the reasons to do surgery on a patient with a cervical problem, cervical spine problem, there's really 3 reasons. One is myelopathy, which is spinal cord dysfunction. Another is radiculopathy, which is nerve root dysfunction. And the last one is pain, whether it's neck pain, pain radiating into their shoulder, headache, pain from the neck, arm pain. There's so many different, possibilities. Everybody's different. There's no 2 people that are the same. But pain is the common denominator. I don't know if that answers your question, Big John. Hopefully it does.
We have a couple more questions.
Sure.
This next one comes from, forgive me if I mispronounce this name, Nahada on YouTube.
Hello, Nahada.
They asked, I just want to ask if there is a risk of adhesion post-surgery at the site of disc which is removed.
No, there's no risk of adhesion at the site of surgery where the disc is removed. Nope. Adhesion requires inflammation, and this surgery gets rid of inflammation immediately. So there's still some inflammation that happens with healing, but because the injured tissue is being removed with the laser, you're basically doing the job of your body's inflammatory system, getting rid of the source of inflammation, which is the dead tissue, the necrotic tissue, the tissue that shouldn't be here, which is what I'm removing right now with the laser. So this laser surgery gets rid of the need for inflammation. So your inflammatory response after surgery is minimal to none. Whereas with other types of surgery, you're going to get a lot of inflammation. This is the very best surgery you can do for a disc injury. Herniated disc, ruptured disc, bulging disc, protruded disc, extruded disc, slip disc. They all have so many different names for the same thing. I didn't create all the names. If I had to call it, I would just call them all herniated disc, because that's what they are, herniated disc. Whether you're a ruptured disc, a bulging disc, a protruding disc, a slip disc, it's all a herniated disc. 8 minutes, 7 to 8 minutes. So we're almost done. Keep going on the questions.
No problem. These next 2 questions come from Big John once more on YouTube. First question, bone spurs. Occasionally you will see some blood from laser shaving / cutting. Do they heal in time? Will
Yes.
they cause any surgery, any pain post-surgery while healing? Will it cause a new bone spur or heal?
No, bone spurs do occasionally bleed if they have a lot of diploic bone in the bone spur, but they don't cause any pain ever. And the only reason to remove the bone spur is to allow the disc to heal properly. As long as the bone spur is not interfering with that, you can leave it alone. You're never going to remove all the bone spurs in a disc. It's impossible. Every human being alive that has spine surgery, no matter how aggressive the surgeon is at removing bone spurs, they're going to still have bone spurs at the end of the surgery. And you can't get rid of all the bone spurs. So it turns out that the bone spurs don't cause symptoms most of the time. And only the ones that are pressing on the nerve or near the nerve are going to cause symptoms, and sometimes on the spinal cord. So I look for those and I treat them with the laser. They're very easy to remove with the laser. But no, they don't cause pain while they're healing, and they don't cause any problems at all while they're healing. All right, so I'm trying to get down a little bit more. Here we go.
This next question from Big John on YouTube asking, I have a DPR question for a friend.
Sure.
If someone has a tennis elbow, would you be able to treat it with a DPR procedure?
Yeah, great question. No. Tennis elbow is inflammation of the musculotendinous attachment and the epicondyle in the arm. The treatment for it is shots, and only shots, and then therapy. So, you know, number one, you want to avoid certain types of movement that make it worse, but you also need the shot. The shot's very important. I had tennis elbow myself, and I got the shot. It went away for 2 weeks, then it came back, and then I did the shot again, and it went away permanently. Some people need 2 shots, some people need 3 shots, some people need more. So PRP? Luis is telling me that Dr. Patel, who treats tennis elbow here at Deuk Spine, he does use PRP, and he said the PRP can be very helpful. Yeah, it works. So we start with a steroid and numbing medicine, and if it keeps coming back with that, then I think PRP would be a good, like, alternative treatment, like more aggressive treatment. PRP and stem cells. So start with the shots. I would do at least 3. And if that doesn't fix the problem, then I would consider PRP and stem cells. Yeah, tennis elbow is very painful. Are you asking me? Yeah, I already told you. Yeah. Yep, we're almost done. Literally less than 5 minutes, so we'll be done. And I'm glad you're asking, because we got a lot of surgery to do today. I want to get these patients recovered quickly. So far, everything is going perfect for her. The changes I'm seeing in the disc are pretty much chronic, you know, long-standing herniations and scar tissue inflammation. I'm just about done. So feel free to, I think I've already marked the next patient, right? Yeah, I think I did. So Henry, I'm just gonna head over there next, okay?
Copy that.
And I can answer a few questions face to face, the old-fashioned way. So type your questions up. Happy to come over there and answer them for you. In the meantime, we are pretty much just about done. And I want to reemphasize, this surgery is for herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, degenerated disc that cause symptoms in patients. Most disc problems do not cause symptoms. Most patients with a herniated disc have no symptoms from their herniation. Zero. Zippo. Nada. So they don't need treatment. Okay? There's a lot of people walking around with disc herniations that don't need treatment because they have no symptoms. But the ones that do, whether it's pain, weakness, numbness, or tingling, they need treatment. One more look this way and we're done.
We have another question.
I'm going to come answer them
Okay, no problem, no problem.
because we're done. I'll come answer your questions face to face. Okay?
Copy that.
Thank you, Henry.
Of course.
All done. All done. Went very well for her. Oh, one little thing there. That's it.
Sitting on, please. Thank you.
Lights on. Let me show you guys the incision. Lights on.
Sitting on, please. Thank you.
Have it back. We're just irrigating, you know, we want to clean out any little pieces that may be in the tube. So we've taken all those pieces of herniation. You guys remember the ones that you saw in there? And the laser released them and they all floated up and out of this tube. You guys see the tube here?
Yes, we do.
All right. I'm going to take it out because we're done. And I'm putting a little pressure. You got to hold pressure. Everybody has little veins, and some people's veins bleed a little bit. But we've lost literally 1 cc of blood. This is pretty much bloodless surgery. By the way, her face is here. She's looking up at you. She's got a tube coming off. She's asleep completely. We're going to wake her up. There's the incision. You guys see that?
Yes, we do.
All right, so let me show you how small this is. Okay, not like ACDF where you tear up the body. Her incision is 5 millimeters. 5 millimeters. All right, so we never get infections. We don't get blood clots. We don't get other problems. This is a very safe surgery. Now we've done 2,000 almost, around 1,950. Probably by the end of next month, we'll be at 2,000 surgeries. We broadcast probably 98% because some patients don't want it broadcast, so we don't broadcast if they don't want it broadcast. We still record and we give them a copy. But all of our surgeries you guys see. If you watch our channel and you watch our surgeries, you're watching 98% of my surgery, Dr. Deuk Machen. Dr. Patel doesn't broadcast. Dr. Davis doesn't broadcast, but I do. And I do it because I like to teach people. And I like people to see what's really going on. And that's the best way to learn, is by watching a surgeon operate. All right, blood loss 1.0 mil. DLDR. Left approach, everyone agree? C5-C7, and we did a DPR first, earlier, and that was a right. Everyone agree? C5-6-7-T1. All right, that was for facet pain. She had facet pain as well. And I've done the study on the lower back. I haven't done it on the neck yet. But for the lower back folks, the most common cause of chronic pain in the back, thank you, is a herniated, is a disc injury. Herniated disc, degenerated disc. And that's responsible for, let's just say 85% of back pain. And then the facet joints are responsible for around 10%. So between the disc and the facet, you're at 95% of pain. In the neck, it's the disc and the facet make up 100%. Okay, we don't see anything else. So the disc is around 90, facet is around 10, 12%. And this patient had both. So, all right, go ahead and run one of our patients' experiences, and I'll be there in just a couple of minutes.
I'm here with my patient who traveled from California, Northern California. He had a herniated disc at C5-6. It was a small disc bulge. He was told by the doctors in California that he should just live with the pain, give it time, and eventually he'll need a fusion. Is that right?
That is correct. I was told that within 5 years I would be needing surgery. So basically what they were saying, live with pain for 5 more years and then we'll do something about it. One of the things that I've seen a lot of the videos is testimonials, and I will always say, this doctor sounds too good to be true. And actually it is true. I appreciate you, doctor. I really think that it was really nice procedure, and the staff here is really nice. Always very friendly and kind to get you through the process, because when you get told so many times that that's your new life, it's kind of, you're always thinking, is really the way I want to live? If I'm going to live a lot of years, why wait with pain? You know, you need to do something different. And always, whenever you see videos, you're always a little sketchy and saying, maybe it's not true. Maybe this is not what it is really saying. But today, when I felt with no numbness and no pain on the neck and just going through the process, I really been blessed. I'll be flying to California today. I honestly can't say much. You know, it's a miracle. Whenever I heard the testimonials, they say you're a tool for God. It actually seems like that's the way it is. It's a miracle through you. God works through you, and it's awesome to feel better, you know?
I'm so happy for you and your lovely wife who's here with you. You can see you had a tiny little incision. You had the Deuk laser disc repair for your herniated disc. You can see we were in there with the laser, cleaning out that foramen on the right side where the nerve was being pinched. There were a lot of pieces of herniation in there. And the laser cleaned them all out, and your surgery went perfect, and here you are less than 24 hours later. Feeling good, huh?
Well,
With
yeah.
a smile on your face. That's what I like to see.
You know, it's a smile of happiness. It's a smile of joy, you know, that it is doable. And I think no one should be able to be living with pain. I was so happy to see testimonials when they used to say, well, the one regret I have is not going in earlier and living 18, 20 years with pain. For me, it's been 3 years since July of 2020. It's been miserable because I've been with pain. And I've been told by doctors, let's just take time. I did all kinds of physical therapy, acupuncture, you name it, everything that's out there, and nothing seemed to help. And today, with 1 day of getting something really that's gonna be for life, it's amazing. It's a smile of joy, you know? If you are going through this trouble, don't hesitate on sending your MRI. When I did it, I sent my MRI for free review, and my answer was, yes, you are a candidate. Here I am today, flying back with literally no pain on my neck and no numbness on my hand, which I miss that. It's awesome.
It's wonderful. Now, what is your native tongue? What is your native language?
It's Spanish.
Are you from Mexico originally?
Guadalajara, Jalisco, Mexico.
Guadalajara.
Yes.
One of my favorite songs. Can you tell them in your native tongue how you feel?
Yeah. Quisiera decirles que si están teniendo problemas con una hernia en su cuerpo, manden su MRI. Es gratis y les van a dar un resultado, una verificación si ustedes son candidatos. No vivan con dolor, porque el dolor les va a causar toda la vida, y los doctores allá afuera les dicen que no hay solución, pero las soluciones existen, simplemente las tienes que buscar y creer, tener fe que tú vas a estar mejor. Si Dios te mandó a este mundo es para que vivas bien, no para que vivas con dolor. Así que te recomiendo que por favor tomes esto en serio, hagas ese paso de mandar tu MRI gratis y habla ya sea con quien tengas que hablar para que ellos te empiezan a guiar y te digan qué es el siguiente paso que tienes que tomar. Así que una recomendación con Dr. Deuk. Muchas gracias.
Muchas gracias, amigo. And Feliz Navidad.
Feliz Navidad. Gracias.
Safe travels, my friend. Thank you so much for sharing.
And I'm Dr. Deuk, and I hope you enjoyed watching this surgery. This was a patient who came to us with pain in her neck that was radiating into her shoulders and down, numbness and tingling in the fingers. We determined that it was coming from her nerves in her neck at C5-6, C6-7 being not just pinched, but more importantly irritated. And, you know, she had a tear in the back of the disc at C5-6, C6-7, annular tear and herniation. I went in with a scope and repaired it. And for those of you who have a hard time understanding or visualizing what we did, take a look here. This is a spine or a segment of spine. You've got bone and a disc between. The herniations are always in the back of the disc. So to get to the back of the disc, either you make a big cut, get down to the spine, peel off muscles and ligaments, and then shave away the disc to get to the piece in the back. Or you do as the Koreans, you know, figured out, You take a little tube, you go through the disc to the back, like right here, you go through the disc to the back, and you use a laser to remove the herniation. Okay, well, I use a laser. The Koreans didn't. They used other tools like grabbers, but the laser is the best. That's what we just did. And the surgery went perfect. We lost one, not even a full cc. A cc is 20 drops. We lost maybe, I don't know, 5 drops of blood. So a quarter of a cc. So it's essentially bloodless surgery. There's no hospital. We're not at the hospital. We're outpatient. She's going to go home in 2 hours. And it's done with her asleep. So it's comfortable for the patient. You don't remember the surgery. You don't remember anything. And it's very safe. We've done now cervical, we've done probably 800 cervicals. Lumbar, we've done about 1,400, around 1,200 lumbars. So definitely more lumbar than cervical. Cervical is less common than lumbar, which is lower back. And then thoracic is the least common. We've done around 25 thoracics so far. So that's the one we've done the least amount. As far as what are our options for treating her, we could have done an ACDF fusion, we could have done a PCDF laminectomy infusion, we could have done an artificial disc, or we could do the endoscopic laser. The best of those, laser. The least invasive, laser. The one that doesn't require pain medication for her discs where we operate after surgery, laser. The other ones require narcotic opioid painkillers. The other surgeries require a long recovery. With laser, the recovery is one night, and then the next day you can go back to work if you want to. You can drive. So the most effective treatment, the one that gets rid of the most neck pain, arm symptoms, headaches, laser. The other one's 50-50. Laser is 99.6%, basically close to 100%. Now, will the laser surgery on the disc fix the facet pain? Absolutely not. The disc and the facet joints are two separate things. Just so you understand, the disc problem is here, the facet joint problem is here. So it's a completely different structure. It's another type of joint, and it's one that most surgeons don't know much about. But the facet joints cause pain in about 10 to 15% of patients. All right, we'll take our first question.
First question comes from AAKK on YouTube.
AKK.
And they say, good morning, Dr. Deuk.
Morning to you.
In your opinion, could this surgery/laser be adopted to repair labral tears in the shoulder or meniscal tears in the knee, as a laser does help seal avascular tissues?
Yeah, it's a great question. I think you're onto something, honestly. Yes, I think you're right, as a matter of fact. I think, you know, the only problem is, to be honest, I'm not an orthopedic surgeon. I'm a neurosurgeon. So I personally cannot and would not feel comfortable or allow myself to operate on somebody's meniscus or their, a torn rotator cuff, because it's not a neural structure. Now, that said, we are curing shoulder pain, knee pain, hip pain through our Deuk plasma rhizotomy. And just so you understand what that is, I'm going to bring a knee in. So this is the knee, right? And it turns out the knee has a nerve supply that includes this nerve, the black line, this nerve, the black line, this nerve, the black line, and these nerves go to the joint and innervate it. And so people that have arthritis in their knee, they have so much pain because of these nerves. These nerves are bringing those signals up to the brain. Well, guess what? I developed a technique to go in and cut these nerves, destroy them, destroy them, destroy them, and that takes the pain away. So we've been doing it now for a while, a year, a couple of years for the spine, but for the knees, 6 months, 8 months, almost a year. And the results are spectacular. People's knee pain goes away, their hip pain goes away, their shoulder pain goes away. Now there are some exceptions, and typically the exceptions are, for example, if you fix their joint pain and it goes away, they may still get patellar tendon pain, which we're not treating, right? The patellar tendon's on the front of the knee, not in the knee. So the other thing they get is maybe some muscle pain because now they're more active, they're using their knee more, so they start getting muscle aches. So the procedure, Deuk plasma rhizotomy, gets rid of knee pain, hip pain, shoulder pain. You don't need a replacement anymore, but it doesn't fix the weakened muscles or tendons or ligaments. You got to build those things back up with physical therapy. So yes, the procedure is amazing, but you got to do PT afterwards. Now, some people are really fit and they don't need much PT, they just do some walking, but some people need therapy after the procedure. But the days of joint replacement are going to go away. Hear me out. Joint replacement is going to go away. Why? Because of our procedure that I developed called the Deuk plasma rhizotomy. And we just got it patented last week from the United States Trade and Patent Office. So very happy about that. They made the decision that it's so unique and new that they patent it. So it's being patented.
That's incredible.
Next question.
Next question. These next two questions come from Rita on YouTube. And first question asking, can you do back and knee the same day of chondromalacia patella of the forming caused by bad walking gait after back injuries from 2 car accidents? Have you done that on people on Remicade or methotrexate?
What was her name?
Rita.
Rita, thank you for asking. Yes, we can fix your knee at the same time as we fix your back, even in the same surgery. We'll do the back, we'll flip you over and do the knee. But I want to make sure our orthopedic surgeon or orthopedist, Dr. Patel or Dr. Davis, has a chance to look at your MRI and make sure you're a candidate for the Deuk plasma rhizotomy. We need your MRI report. So if you're going to have your back fixed, send us your MRI through our free MRI review on our website, but also send us your knee MRI report so that we can look at your report and figure out if you're a candidate for the Deuk plasma rhizotomy for your knee. Chances are you are. We can do it all in the same surgery.
Next question from Rita asking, what happens if have been on opioids since 2008 since accidents? Since you don't need meds after your surgery, thank you, doctor. I told a lot of people of you. I'm just not getting answers here if I can.
So Rita, if you're on opioids, okay, and you have our surgery and we cure your pain, you cannot stop the opioids overnight. You'll go through withdrawals. It's dangerous. You could have a seizure. You'll have anxiety, chest palpitations. Don't stop your opioids immediately. So what you would do is you would keep taking them after the surgery for a week or two, probably 2 weeks, where you would cut the dose in half for 1 week. Then you would cut the dose in half again for the second week. Then you can come off of the opioids. If you have a patch that you're using, you would ask your doctor to give you a lower dose patch. Like if you have a fentanyl patch, you would take a lower dose, so you just take that lower dose for a week and then you would switch to a lower dose for the week after. But you cannot stop opioids cold turkey. Opioids, benzodiazepines cannot be stopped cold turkey.
Next question comes from Nahada on YouTube asking, is there a rule for hyaluronic acid / collagen hydrogel intervertebral disc injury in treating the defect we made post discectomy?
No. Yeah, so the doctors, scientists have studied the roles of biologics and implants in the disc, be either alone, standalone, or after surgery. And I will give you my opinion, okay? They don't work. They're unnecessary, they don't work. All you need is the Deuk laser disc repair. You don't need anything else put in there. We've been doing this for 17 years. Our patients we did 17 years ago are still pain-free, okay? You don't need any biologics, any implants, okay? Here's the problem. Our field of spine surgery is controlled by companies that make money off of selling biologics and implants. They make billions of dollars a year. They're very powerful, very wealthy companies, okay? They bring in investors from Wall Street who want money. And they're just about one thing: sticking things in your body. It turns out you don't need those things when it comes to your disc. You don't need them now when it comes to your joints. We can fix arthritic joints, painful joints with the Deuk plasma rhizotomy. We can fix your disc with the Deuk laser disc repair. Neither of those procedures need any implant. You do not need hyaluronic acid. You don't need anything stuck in your disc. The stuff that's gone, the nucleus, it is not necessary to have a normal functioning spine. You don't need it. Your spine will work just fine without it. Everyone tries to convince you you need it, but you don't, okay? You need the nucleus in your disc like you need herpes. You don't need it. You don't want it, you don't need it. The only reason the nucleus is there, hidden away in the disc, is because it's so irritating to your nerves. It creates inflammation. So your body tucked it away and hid it in a prison, which is the center of your disc. If you don't have it, you're better off. Trust me. But since your body has to stick it somewhere, it stuck it in the middle of the disc. Now, you may be asking, well, then why do we have it in the first place? Because it's a remnant of the fetus. During embryological development, the notochord, look it up, Notochord, which is very important in differentiation of cell lines to become adult cell lines like endoderm, mesoderm, ectoderm. That structure, the notochord, becomes your intervertebral disc. But your body would love to just get rid of it, but it just doesn't have a way to. So here we are with these cushions, the nucleus pulposus, the hyaluronic acid, but they are in prison. And I'm the first in the world to recognize this. I've been saying it now for years. The nucleus is not something you need structurally. Lots of people don't have any nucleus left. It's gone. And they have zero symptoms. They have normal lives. And we don't want to try to replace the nucleus, okay?
We got two more questions. This next one comes from Diver X on Facebook, asking, even the degeneration of discs like L5, L4 to L5, L5S1, can they have remedy?
Yes. So Diver X, I'm a diver by the way myself. I don't know what kind of diver you are, but I am a scuba diver. I just got my rescue diver certification, which I could have gotten years ago, but my daughter is a scuba diver. We did it together. Long story short, we can fix your L45, L5S1 degenerative disc. Now, if you have Diver X, let's say somebody has degenerative 4551, right? They have zero symptoms, no back pain, no leg symptoms, their nerves are fine, they have no back pain. There is no reason to have anything done. Leave it alone. You're the best you're going to be. On the other hand, if you're having back pain from it, then you want to have a treatment. And the treatment that fixes it the best is what you just watched, Deuk laser disc repair and Deuk plasma rhizotomy. That will get rid of the symptoms from your degenerated disc. It will not get rid of your degenerated disc, it will get rid of your symptoms. You understand what I'm saying? Yeah. And it's the safest and best way to treat it.
This next one comes from Rita, it's more on YouTube, asking, can you be on Remicade and methotrexate treatments while having your surgery, being immunocompromised? What is your opinion on Duralone? Injections is not helping enough to get okay for surgery. I have Takayasu arthritis and already had a stroke.
Yeah. All right. So we've had patients with Takayasu's arteritis already, and we can leave you on your Remicade and methotrexate, no problem. We can do the surgery without taking you off. You can see how minimally invasive it is. It's entirely possible. We're able to do it. Obviously, you're going to have a slight risk of complications that's higher than somebody without Takayasu's arteritis, but it's not a problem. Not a problem.
Next question from AAKK once more on YouTube, asking, the laser for the DLDR is excellent. Do you see any improvements down the road to the laser device itself? Or are you looking to ever develop your own laser? How would you design
and improve.
I like this AAKK guy.
I love
He
it. He's
thinks
very
like a business person. Guy, gal, whoever you are.
Yeah.
But that said, I think you're onto something again. Great idea. I've thought about it. Yes, there are definitely improvements that can be made with the laser from a functional standpoint for me, the surgeon. I would like a larger caliber laser. But here's the problem. As the diameter of the fiber goes up and you get bigger, then the amount of power you got to pump through that to have an effect on the tissue goes up. And the lasers are already at 100 watts, 100 watts, which is pretty damn powerful. So you'd have to have a more powerful laser to do that. So yes, I agree with you. I think there's definitely room for improvement. And would I want my own laser? Yeah, I would love to have my own laser someday. But something a lot of people don't understand about Deuk Spine Institute, I almost wish we could take the camera and walk around the building.
I know.
We're a 20,000 square foot facility. We're like a tiny company here, even though we're making a big noise. We are, if you've ever heard of the play, The Mouse That Roared,
Yeah.
we're not getting ready to start a nuclear war, but we are trying to change healthcare for the better of patients. And we're making a noise, a big noise, but we're a tiny company. We don't have resources, we don't have money. We got, we make it, we're in the black, but we're not, a hospital that has $1 billion. We're a small company. So yes, I think there's definitely room for innovation. I would love to have our own laser, but that would cost a lot of money, which we don't have. That would cost millions of dollars. So right now we do the best with what we have, but I think there's definitely a way to improve the laser and the fiber, both, to improve the efficiency of the surgery.
And that is it for questions.
Okay, thanks for joining us. It turns out our next patient, who is from, I think she's from Chicago, if I'm not mistaken. I will find out. She's out of state. She's actually originally from South Korea. She's having the same surgery. She's having facet treatment first, and then we're going to flip her over and we're going to do
To Virginia.
Virginia.
Yeah.
Sorry, she's from Virginia. We're going to do her facets, and then we're going to do her DLDR. So she's next. She's coming back soon. We're going to put her to sleep. We'll do her facets. It'll take me 10 minutes, and then we'll flip her back over and do her DLDR 2 discs. And then after that, I'm not sure what we have, but we have 7 surgeries today. So, yeah, this may be more than a popcorn day. It may be a pizza day. Nice of you to join us.